You're about to watch this video, but if you're an optometrist, you should watch it on our website instead, because then you can get CE credit for it. So click this link here and you can watch this exact video, but receive CE credit for doing it. My name is Jack Parker, and I'm an ophthalmologist, a cornea specialist at Parker Cornea in Birmingham, Alabama. And the purpose of this CE talk is to discuss the disease entity of keratoconus. Keratoconus is one of the most common blinding corneal diseases in the United States and indeed in the world. So you have to know about it. It's a very common problem that afflicts predominantly young people and results in preventable, sometimes bilateral blindness. So its importance is one of the reasons why it is of critical necessity that you know about this entity. And the second reason that it's important to know about what's going on in the field of keratoconus is that it is drastically different now than it was even 5 or 10 years ago. The way that we manage this condition, the way we diagnose it, is totally different than how it used to be when many textbooks which are used for educational curricula were written. So what we would like to do here in this little lecture is to explain the modern take on this blinding disease of young people, how it's diagnosed, how you may conceptualize it like a cornea specialist, what you may do for your patients, and what you can recommend in terms of treatment. So the structure of this presentation is these are basically a few prefatory remarks, some sort of backgrounds on the condition with the context of patients that we have been seeing, case examples from our own clinic. So by way of introduction, I would like to remind you about what keratoconus is defined as. So keratoconus in the textbooks is defined as a bilateral progressive disease. And oftentimes what you read in the textbooks, you think, okay, well, it's just more or less scientific jargon, and why is that important? But in this particular instance, it is relevant to the definition because it tells us important prognostic information. So first, keratoconus is always present in both eyes. If you see a patient with a cone in one eye, it may be less clinically manifest, but this is always a disease of both eyes, and it is defined as a disease that gets worse. Keratoconus is definitionally a progressive disease. So if you see a patient in your office who has keratoconus, you should be thinking of this is somebody who, if left to their own devices, is going to get worse. This is someone who is going to lose vision by definition of the disease entity if you don't do something. Now, a lot of people tell me that, keratoconus, I never see it. I never see it in my practice. And if that's you, if you never see keratoconus, you should be careful, because just because you're not seeing it doesn't mean it's not walking through your doors, because keratoconus is very common. In the United States, it's especially prevalent in areas that have a high incidence of allergies, and that would be the southeastern United States in particular. But if you just look at the US in general, the key statistic that sticks out to me is that the incidence of keratoconus in patients who present with a chief complaint of I need LASIK is 1 in 10. And the reason is these young people with poor, worsening, changing, fluctuating vision think that they have a LASIK deficiency. They think my vision is poor, therefore I need LASIK. But they don't know. They're coming to the doctor, they're coming to you because they can't see. So a huge percentage of these patients have keratoconus. So if you see any significant percentage of refractive patients in your practice, you should know that 1 in 10 people who come seeking laser vision correction have keratoconus. And it is a major miss if that is not perceived before their operation, because any kind of laser refractive surgery is likely to make them much worse. Now, there are other corneal ectasias aside from keratoconus. Keratoconus, you may remember, is a condition of corneal steepening and thinning in which the steepest part of the cornea is also the thinnest part of the cornea. The apex of the cone is the steepest and the thinnest part of the cornea. Post-LASIK ectasia is another very common corneal ectasia. It looks just like keratoconus. The steepest and the thinnest part of the cornea are coincident. But what distinguishes post-LASIK ectasia is these are patients who frequently have had LASIK in the past and will tell you that was the best money I ever spent. I'm thrilled with that operation. And as time goes on, their own subjective experience is, oh, the LASIK is wearing off. My vision is worsening. And characteristically, a post-LASIK ectasia patient presents 10 years after LASIK. And that is a dangerous presentation because the patient usually does not suspect something is seriously wrong. They come back to the eye doctor, they say, I need glasses, my LASIK wore off. Their procedure was 10 years ago, no one's expecting a complication, but that's the most common time for post-LASIK ectasia to present. 10 years after the refractive surgery. So that's something to keep in mind. If you're seeing patients with this remote history of laser vision correction, that does not mean that they're safe from the complication. It may mean that this is the time they are most likely to develop it. Another condition that you may have heard of that involves corneal ectasia is this pellucid marginal degeneration, PMD. And what's special about PMD patients is the thinnest point and the steepest part of the cornea are not coincident. The steepest part is central and the thinnest part is inferior. It's the bottom of the cornea. And you might say, well, who cares? It's an ectasia. Why does it matter? What the difference between pellucid and keratoconus? Well, the first reason is because pellucid patients present differently. Your average keratoconic patient is in their teens or 20s and are rubbing their eyes like crazy. Pellucid patients present much older. They're in their 50s or 60s. And when you ask them, do you rub their eyes? They typically say no. And so you may have to think about this particular ectasia in a different age demographic. If you see somebody who's 50 or 60 and you say, well, this person's too old for keratoconus, that may be true, but they may have this related entity, this other corneal ectasia, pellucid marginal. Now, I want to share with you, with that background put aside, patients that we've seen just in the past couple of months in our practice. This is a patient who was referred to us by a local optometrist. He was 24 years old, and his vision was 20/20 with his glasses, but he sort of had these subjective visual complaints. He said, well, I got glare, and I sort of see double. When I look at something, I have sort of double vision. It's a very common complaint. These sort of vague, subjective visual disturbances, yet correctable to 20/20 with his glasses. And this patient, who's a real patient, had been variously misdiagnosed in the past. He'd been told, like many of these patients are, well, you're 20/20 with your glasses, therefore you've got nothing seriously wrong with you. And these weird complaints you have are likely secondary to dryness. So the patient was treated with topical lubricating drops for a while before someone suspected the issue and referred them to us. So these are the patient's pentacams, their corneal tomographies of the right and the left eye. And what you'll notice from these 4 maps displays in each eye, the most salient is the upper left image for both eyes, and that's the axial curvature. What you can see displayed here is that the axial curvature map shows that the cornea is inferotemporally steepened. So an inferotemporal steepening is characteristic of keratoconus, especially when the cornea is also locally thin in that area. So this is a patient who has keratoconus. This is what early keratoconus looks like. 20/20 subjective visual complaints, corneal steepening imaging, corneal steepening revealed on maps. So what do you do about it? Well, the major concern for this patient is that this would get worse. Remember, keratoconus is defined as a disease that gets worse. So this person may be 20/20 now, but they will not be 20/20 in the future if something isn't done. So this is the critical opportunity to intervene. This is a kid who's going to do well if you diagnose them and arrange for their treatment, and they will not do well if you miss this or if you don't take action. And the key thing to be done here is, number one, you tell the patient, do not rub your eyes, because eye rubbing for sure makes keratoconus get worse. And number two, these are patients who need to be cross-linked. The purpose of looking for keratoconus in these early stages is to arrange for cross-linking. Now, what I tell my patients about cross-linking is I tell them that it used to be that there was no good treatment for keratoconus. We would tell people, basically, don't rub your eyes. This is a disease that will get worse. As it gets worse, you'll outgrow your glasses. You'll end up wearing hard contact lenses. Those may stop working after a while, and eventually you'll need a corneal transplant, and we'd like to delay that operation as long as possible. That's not what you tell people now. Now you don't say we should kick the can down the road as far as possible. Now you say we should intervene as early as possible to preserve the anatomy of the cornea. Cross-linking is an extremely effective treatment for keratoconus that stiffens the cornea, which makes it resistant to further changes in shape. What's amazing is that this treatment works in vitro, which means you can take strips of pig cornea and you can cross-link these pieces of cornea. And what you'll notice in this depiction here is that this does not require a biological reaction. This doesn't depend on how the patient heals or anything that they do. It's a mechanical effect that strengthens the cornea and stiffens it basically by 4.5 times compared to normal. The practical effect of that is it makes the cornea much more resistant to further changes in shape, either naturally or as a result of eye rubbing. The success rate, the published success of cross-linking and stopping the progression of keratoconus is on the order of 97%. So the vast majority of people who are treated with cross-linking will see a cessation of the progression of their disease. So cross-linking is not done to improve somebody's vision. So if you've got somebody who's 20/20 and they're happy with their vision, you don't think, well, okay, this person doesn't need cross-linking because they're satisfied with their vision. Or you don't think, okay, well, this person's correctable with their glasses or contact lenses, so we don't need to cross-link them. That's the reason to cross-link them, because since it doesn't improve somebody's vision, you want to do it when they're still seeing well. The earlier you can cross-link somebody, the better, because it keeps the horse in the barn. Now, the key thing to keep in mind when considering arranging cross-linking for a patient is that keratoconus is not just by definition progressive, it is by definition rapidly progressive. This is an interesting study that was accidentally performed in Italy back during the hardcore COVID lockdown. And this is a news report about that study, and let me tell you what this news report discovered. Basically, right before Italy locked down for hardcore COVID, there was this big queue of patients that had been diagnosed with progressive keratoconus, and they had been scheduled for cross-linking. But then COVID hits, and everything in Italy shuts down. And for 3 months, those patients who would have been cross-linked sat at home. Then after 3 months, things start to open up again. The hospital starts opening its doors to non-emergency pulmonological cases. And these patients who were going to be cross-linked but weren't came back in to see the ophthalmologist. And what this study found is that in a 3-month delay, after delaying cross-linking for 3 months, 70% of those patients got worse permanently, had a permanent change in the shape of their cornea, resulting in, on average, 1 line of best corrected vision lost permanently in 3 months. And that is so important because we see lots of young people who've got keratoconus and they've been diagnosed with progressive disease and they need to be cross-linked. And the patient says, okay, well, look, I'm fine, but I'm in high school or I'm in college and it's February and I've got exams coming up or I've got things to do, and what I would like to do is let's wait until the summer, or let's wait until school's out. Can I wait? Can we just put this off 6 months? And the answer is no, you cannot wait 6 months, because there is a 70% chance the shape of the eye will be permanently worse. Just imagine that you have cancer, basically, and you're asking your surgical oncologist, okay, well, I understand this needs to come out. Can I wait 6 months? The answer is not just no, it is hell no, because you are likely to be worse off in a permanent way if you delay treating what is a progressive, potentially blinding disease. So that is an extremely important concept, that time is vision. Now, all the time, we see people who have got pretty good vision, and they think, well, as a result of this pretty good vision, I really don't need any treatment. It's okay just to watch me because I've got pretty good vision. This is not totally dissimilar to thinking that, well, you've got this patient in your office and their vision is 20/20 on the eye chart, but their intraocular pressure is 42, and you think, well, there's no real reason to intervene here because they're still seeing pretty well. The reason that doesn't make sense is that glaucoma is a blinding disease, even if the patient doesn't subjectively appreciate a change in their Snellen acuity. These are 4 pentacam images that show horrific ectasia, horribly warped corneas, and yet the patient is still 20/20 in each of these 4 cases. So you cannot determine whether or not someone is anatomically declining according to how many letters they can read on the eye chart. And it's basically your obligation to recognize the impending danger and get somebody the treatment they need before they start permanently losing vision. And if you're wondering, is my person getting worse? Is my patient that I'm in charge of, are they getting worse? Well, they must not be, because their vision is still 20/20. That is not a reliable indicator, because you can lose a horrific amount of corneal anatomy before it manifests in a change of your vision. That's what these images show. Your cornea can be drastically changing before your vision changes. So the only way to know is to image the patient's corneas. They need topography or tomography. You need topography or tomography if you're following these patients. And if you don't have it or don't want it, these patients need to be referred somewhere they can get that imaging. Just like if you're following somebody for glaucoma, you need an OCT, or you need a visual field, or you need cameras that can take pictures of the nerve. You can't just follow a glaucoma patient according to their vision, and it's the same way with your keratoconic patients. So it is a huge misconception that patients with good vision don't need treatment. That's who needs treatment the most. That's who can benefit the most. Crosslinking can be done in 2 ways. There's an epithelium off version and an epithelium on version. The thing to keep in mind is the epithelium off version of the procedure, where you take the epithelium off, then soak the cornea in riboflavin for 30 minutes, and then turn on a UV light for 30 more minutes. That's the FDA approved version. That's the version that everybody's insurance covers. So that's the one that you should arrange for your patients to have if you don't want them to have to go out of pocket for a procedure that should be covered by their insurance. Now, when patients are cross-linked, it's typically done in the office. It takes an hour, and that consists of first just debriding the corneal epithelium. That takes just a few seconds. Then lying the patient back and dripping a riboflavin solution over the eye for 30 minutes. And then 30 more minutes of that riboflavin while they look up into the UV laser. What I tell patients is that the procedure is not exciting, it's not fun, it's not painful, it's boring. We have lots of people who fall asleep during the cross-linking. When it's over, the eye is typically patched shut without a bandage contact lens, because there are really good studies that show that the bandage contact lens does not improve comfort with this epithelial defect in patients who've had cross-linking, and further, that a bandage contact lens with cross-linking patients increases the risk of getting an ulcer. So we don't recommend a bandage contact lens, just a pressure patch, which stays on for 3 days. After the pressure patch comes off 3 days post-operative, the patient starts some antibiotic steroid, which they use 3 times a day for one week, and then they can stop it. After those first 3 days, when the patch comes off, the epithelium should be intact, and it should certainly be intact after the first week, and at no point should there ever be a corneal infiltrate. If there's an infiltrate, if there's an ulcer, something is drastically wrong, and that has a very low probability of occurring if no bandage contact lens is used. These patients can continue to use a topical steroid if they want after a week of the procedure if they're still uncomfortable, but most people are doing pretty well at that point, and their drop can just be stopped after the first week. Now, when you have cross-linking done, most patients will say, my vision is worse, my eye feels worse. When you check their vision on the eye chart, it's worse. And when you measure the shape of the cornea for the first 3 months, it's worse. So right after the procedure, for the first few weeks, everything is worse. That's normal. And what I tell people is that what we're doing here is we're doing basically construction work on the cornea. And you can imagine if you've ever hired somebody to do construction work, for example, remodeling your kitchen. Imagine you're 2 or 3 weeks into the job and you walk into the kitchen and the kitchen looks just normal, looks like a fine regular kitchen. You would be furious. You would say, well, what are you bums doing? You would expect to see ripped up floorboards and dangling wires and exposed pipes. You would expect to see evidence of construction, of men at work, okay? And that's really what you expect to see in the first few weeks or month after cross-linking. You expect to see evidence of men at work. The cornea is hazy and the eye is light sensitive, and it is healing and remodeling. There is epithelial hyperplasia, and that's why every single part of the eye is worse for the first few weeks. But what you notice after that, over the course of the next especially year, but really even 2 or 3 months, everything gets better. Typically, the cornea flattens by a couple of diopters, which often results in improvement in the patient's best corrected visual acuity. The haze diminishes, the comfort returns to normal, and everything improves. But the first few weeks, you have to coach the patient as their doctor that, just like if you had a rotator cuff shoulder surgery, for the first little while after the surgery, shoulder hurts worse, your mobility is worse. That's the body healing. Cross-linking is a great procedure to stop the progression of the disease, but it doesn't make your vision any better. What I tell people, it's like imagine your house is on fire. The firefighters, they'll come put the fire out, but they're not going to rebuild the house. They're not going to buy you new furniture. So that's why you want to call them early. But if you want to improve your vision, you need something else besides just the firefighter. So cross-linking is good, but it's not the end-all be-all. There's another procedure which can be done with cross-linking, and that is the subject of this case presentation. This is a patient. He's a young man. He's been referred by his local optometrist. He's got worsened than 20/20 vision. His vision is only 20/30 with his glasses, and he's got keratoconus. So what do we do for this person? Well, obviously, we're going to cross-link this guy because his vision is changing. It's getting worse. He's got a progressive disease, but he wants to see better. So what can we do to make his vision actually better? Well, in the past, there was this procedure called intacs. Intacs are these little pieces of lucite, of PMMA, that are put into the cornea. And these little pieces of plastic can depress the cornea in the location in which they are inserted. So if you have a locally steep area of the cornea, you put these plastic segments in and it brings the cornea back down. Intacs are really interesting pieces of technology that we've used for a long time, but there are some disadvantages to them. Number one, not everybody's eligible for intacs because the cornea can't be too thin or too steep, or the plastic segments will erode out the top of the cornea. The other thing is this is a foreign material. A foreign material put in the body, you can get infection, you can get melting around the segments. And then furthermore, because this is a piece of plastic, you can get glint or glare off the segment. So intacs do often make the vision better, but they've got some potential long-term risks. And sometimes the patients report they don't like the glare from the segments, and so they're not satisfied with the vision. But this concept resulted in an improved version of this operation, which has been around for a few years, called CAIRS. CAIRS is the exact same idea as intacs, but instead of putting a piece of plastic in the cornea to flatten it, instead we use a piece of collagen, specifically corneal stroma from a donor cornea. It turns out you can use little pieces of donor cornea put into the recipient cornea, and it achieves an enormous flattening effect. It's much more sizable, the change in the corneal shape, than you get with plastic segments, because you can use big collagen strips and they won't erode or melt through the cornea. And you get no glint or glare off these segments. So the patients usually get a much better improvement in the shape of their cornea and much subjectively improved quality vision. Here is that patient who had crosslinking done, followed by CAIRS implantation. The leftmost image, that's the preoperative picture. The centermost image is the postoperative picture. And the rightmost image, that's the postoperative difference. And what you'll notice is that this patient had 13 diopters of flattening of their cornea in the nose of the cone, at the apex of the cone. So a drastic regularization of the shape of the cornea following CAIRS insertion. This is the only procedure that I know of that can change the shape of the cornea that drastically. Just imagine if you had a K-max of 58 and someone told you tomorrow it can be 45, are you interested? The answer is obviously yes. Here's another example. This is a patient that had CAIRS done. The centermost image, that's the preoperative image. The leftmost image, that's the postoperative. And the rightmost, that's the difference map. And you can see what a drastic change in the shape of the cornea. Turns out this is even more effective. You can get 20 or 30 diopters of flattening if you perform this procedure in a very ectatic cornea. If you've got a K-max of 70 or 80 diopters, the cornea is so pliable, so loose and amenable to reshaping, you can get humongous changes in the shape of the cornea and potentially avoid much more invasive option of a full thickness corneal transplant. So I think CAIRS is a new, very effective treatment for improving the shape and regaining vision in somebody who's lost vision from keratoconus. And the last sort of case example I want to review with you. This is a patient who's referred to us. She's 29. She has these suspiciously quasi-steep corneas in both eyes and a prescription of -11 in both eyes. She wants LASIK. That's why she came to see me. But of course, you'd be a crazy person to contemplate LASIK in an eye like this that may have early keratoconus already. Somebody that you'd be worried about creating keratoconus by thinning and ablating their cornea. But she's miserable. She's -11. So what can be done for this keratoconic suspect? Can anything be done to improve her vision beyond what she gets with glasses or contact lenses? And the answer is yes, there's a great option for these people. It's an ICL. An ICL, an implantable Collamer or contact lens, is not an anterior chamber lens. It's a posterior chamber lens. It's a lens that goes behind the iris in front of the patient's natural crystalline lens. This can correct prodigious amounts of myopia, up to -16 diopters with 4 diopters of cylinder. So somebody that comes in who's a -20 plus 4 is totally correctable with this ICL. The ICL is implanted in the eye in a minor procedure. Both eyes can be done in the same day in the span of 10 minutes, resulting in basically fully corrected vision the next day. What's nice about the ICL is it's a good refractive option for keratoconic patients because it bypasses the cornea. You don't make cuts on the cornea. You don't ablate the cornea. So somebody with humongous myopic astigmatism can have an ICL placed. It goes in the ciliary sulcus, as I mentioned. In order to put that ICL in appropriately, therefore, you have to have good measurements of the ciliary sulcus. We use anterior segment high definition UBM in order to measure that space. And what we see after the operation is the ICL is very, very subtle. it sort of hides, it almost blends in with the eyes, with the patient's natural lens. It is much thinner, it's much more difficult to observe than an IOL. The central part of the lens is only 2 microns thick. That's half the thickness of a red blood cell. So this is vanishingly difficult to perceive in the eye, even if you know what you're looking for. When you look at the results of ICLs in high myopes with astigmatism, and you compare it to LASIK, for instance, which these patients aren't really even candidates for, what you find is that the quality of the vision is so much better, because when you do laser surgery on the eye, there are these issues with how is the patient going to heal? How are they going to tolerate the procedure? Is there going to be regression? But you don't have regression when you give somebody glasses or a contact lens. You don't have the body fight those things. You don't have to worry about healing. So the refractive stability and predictability is so much better. The amount of uncorrected residual refractive error is vanishingly low with an ICL compared to basically any other surgery out there. So ICL, I think, is the very best option for high myopes or high myopic astigmatic patients, especially your keratoconic patients who can see well with glasses, but who want to be free from their glasses. This is a refractive surgery that they can actually have. So what I would say is that when you're thinking about keratoconus, I want you to remember this is a very common condition. We see it every single day in our practice, lots and lots of patients, and I never make the diagnosis. As a corneal specialist, they never come to me with people not knowing what they have. They're referred because someone else, you, has made the diagnosis. So that's the key thing. The only person who's going to diagnose these patients and figure out what the heck is going on is you. So it's very important to have a high index of suspicion and to be action-oriented. If you see somebody and you think this person may have a progressive blinding corneal disease, those patients need to be treated with crosslinking ASAP. And to regain some vision, they may be candidates for CAIRS or ICLs, depending on the other conditions of their eye. So I hope that this has inspired you to sort of think about keratoconus in a new way and to take up the mantle of trying to bring the very latest and best treatments for these patients in your practice.